good evening, everyone. Thank you so much for taking the time and spending a brief few minutes with me tonight. Everyone can see our slides okay, and you can hear me okay?
Yes, thank you.
So I'm Dr. Phoenix Nguyen. I'm a gastroenterologist, and I work at Mission Hospital. And Dr. Korc and I, who you'll hear about later, we are therapeutic endoscopists. So we do therapy in gastroenterology. So a lot of things we cover will be a little bit more than the general GI topics that you would hear about. We do some common things as well. And I wanted to share with you a very common entity within gastroenterology tonight for about 10, maybe a little bit more than 10 minutes, and then we'll leave time for questions and time for Dr. Korc, my partner, to talk to you also. So this is going to talk about bowel and bowel issues and control of the bowel. And it's a very common issue. So either we have it, I have it, you have it, or you know of someone, your mom, sister, or someone who has this condition in the family that you can help by education. So this is a little bit of an education journey. So Life Without Limits, understanding treatments available for bowel control and what is available. This is to tell you how frequent the condition is, and you really are not alone. Fecal incontinence is common. It occurs, and some of the studies report 1 in 12 adults. And women, men, all ages can have it. One pretty commonly quoted study reports that 1 in 15 women above the age of 65 are affected. And the majority of the patients who are admitted to a skilled nursing facility or an assisted care facility are admitted because of the problem of incontinence, and specifically fecal incontinence or stool incontinence or bowel incontinence. I think those are similar terms. And so if you think about it, 1 in 15, that's pretty common. So about 7% of the population above the age of 65. And living with this condition can cause very serious problems. And it's a big problem for the US because we spend a lot of money taking care of these issues for our patients. And it leads to embarrassment, depression, of course, lower quality of life. Patients are very limited as to what they do. Mostly patients are affected, they stay home, they don't talk about it, it's very secretive. So I'm here to be very open about it, to share with you some of the things that we can do to help with this condition. So if you look at the US population and you compare it to patients with Alzheimer's, patients with asthma, fecal incontinence, 20 million. And it's like, wow, compared to a quarter of that who are affected with dementia or Alzheimer's. So it's a significant issue. And so I'm going to define some of the terms. And so what is normal? So bowel incontinence or leakage of stool is not a normal part of aging. So as we age, a lot of things can happen. So, your muscles atrophy, your strength and your mobility. But as we age, incontinence is not an expected thing. So things like frequent bowel accidents, when we pass a little gas, we leak a little bit of stool, not normal. When we have to plan our activities with our family around where the restroom is available. Sometimes when patients go on a walk, as simple as a walk, they have to say, okay, I'm going to take a certain path because I know on that path there's going to be a restroom. So it's just not normal to have to plan around the availability of a restroom. Sometimes patients have to monitor how much they eat and how much they eat, because what you eat is what you get out. So what you put out has to do with bowel control. Using pads, protective garments, doubling up on the underwear, wearing double layers, pad use is not at all normal. And so as we age, we look at some of these things, and patients don't want to talk about it so much, and they think this is the way it's going to be. So we want to hear about it. We think this is a neglected area in medicine. So if you look at some of the gastroenterology journals, they'll say that fecal incontinence is a neglected area. It's something we do not focus on. We do not want to talk about this because we don't have much to do. We can't really treat it. It's not a condition that's going to kill you. It's not a malignancy. You can live with it. So there's not a lot in the literature, and the data, publications are limited. So it's a fairly neglected area in medicine. So what can we do? Okay, let's see. So I'm going to address first how this works, and then we'll talk about what are the diagnostic testing, and then what can we do to help with this condition. So what happens is the GI tract, or the intestine, is when you chew your food, it goes into your esophagus, into your stomach, small intestine, colon, and then out the bottom. Okay, so and then at the bottom, there's an anal canal. So the anal canal is usually a little bit shorter for women, a little bit longer for men, but it's a set of sphincters that kind of hold the structure in place and keep your pelvis from falling, okay? And the digestive system kind of pushes things through after we eat. Nerves signal to the brain to relax the anal sphincters. And when the rectum is full, it kind of simulates some of these nerves to go back to your brain, and then your brain will act to work on some of these muscles. So the communication between your brain and the bowels is very important. And when the communication breaks down, the nerves are not so functional, then some of the bowel issues can occur. That is only actually one component of it. Incontinence or continence, maintaining control, is multifactorial. So there are many different factors that go into maintaining bowel continence. Okay, so what is fecal incontinence? It's caused by, what are the causes of fecal incontinence? So the most common things we look at in the female population is prior to childbirth. Whether it be vaginal delivery or a C-section, it's childbirth related to the number of children, so multiparity, whether it was complicated childbirth, whether, any complications including tears, any repairs, any babies that came out wrong requiring suctioning device or forceps use. So these are some of the risks that predispose patients to have problems in the future. Patients with men who have prostate cancer and have had prior radiation can predispose. Surgical injuries like hemorrhoid surgery, anal fistula surgery, and incontinence symptoms can, like we said before, can be with frequent accidents. It can have, you can have urge incontinence, meaning you have the urge to go and you cannot hold that urge and you cannot make it to the restroom. Passive incontinence is when you actually have the bowel incontinence, you're incontinent of the stool, but you're not able to sense it. So these are some definitions and pathophysiology and why it occurs. Again, the most common etiology in the female population prior to childbirth. In the male population, probably, I think, radiation from prostate cancer. Patients who are diabetics can have issues. Patient with neurologic conditions, it's not included here. Okay, so causes. So when we look at patients with this condition, some simple diagnostic tests to begin with are, especially in patient population above the age of 50 who have not had a colonoscopy, the number one would be to have your gastroenterologist look in the colon, make sure there's no colon cancer, tumor, any anatomic abnormality in the colon that can be associated with incontinence. I think ruling out a malignancy or a cancer is probably the most important. Some other diagnostic tests would be an ultrasound evaluation we often do, looking at the anal sphincters, look for integrity. Is there disruption of the muscles? Is there thinning, thickening? And a functional test that we do using a manometry catheter, looking at pressures in the anal rectal area, how much pressure is generated when you're at rest, how much are you able to squeeze on top of the resting pressures. So some functional information. We also look at a sensory component because, like I said, the continence is multifactorial. So it's not only the nerves like we talk about from the brain to the anal canal, but also the muscles in the area, the compliance of the rectum, and the consistency of the stool that gets to the rectum. So after some diagnostic testing, we talk about very conservative treatment options. And some for milder conditions, it can work. Sometimes I start off with some dietary modifications because, again, what we put in is what we get out. So it could be as simple as adjusting some of what we eat to form up the stool so that the stool is not so loose and watery that will leak. Physical therapy combines a combination of different things like biofeedback. So biofeedback is done with a pelvic floor physical therapist typically, and they are training sessions. Just like you go to the gym and you have a trainer work on your arm muscles, we have pelvic floor physical therapists that work on the pelvic floor, and they train you to use the muscles that we're not familiar with. So it's very difficult for you or for people to say, okay, let's say your brain is going to squeeze the muscle in the anal canal. It's much easier to say, okay, brain, let's use this muscle, let's squeeze. You can do that. But for here to say for the anal canal to squeeze, it's not easy. And even for a physician like me who do this for a living, it's very hard for me to say, okay, I'm going to sit here, I'm going to squeeze the left side of the anal canal. There's really not a trainable mechanism. And so the therapist would work with you, with the patients. So biofeedback would be a way to do it. And the therapist would train some of the muscles and give the patient the feedback as to what they're doing. And the feedback is given by different ways. It can be using pressure tracings or nerve tracings to feed back to the patient as to how effective they are at our training. So biofeedback, pelvic floor physical therapy also encompass things like pelvic floor acupuncture, pelvic floor Pilates, pelvic floor, pretty much the whole gamut of everything in the pelvic floor to improve symptoms. Medications, the limit in the medication is we have the anti-diarrhea medications to kind of bulk up the stool. We use a little bit of fiber. We use, some simple medication to change the consistency of the stool. So these are some conservative treatments, more advanced therapies. Before, we've gone through full circle in terms of the therapy that are out there. I think I'm talking too much. Let me see if I can speed this up. Chelsea, how are we doing? May have 5 more minutes to go over the therapies.
Yes, absolutely.
So prior to what's currently available, we've done bulking agents. So we've injected agents into the anal canal that can bulk up the anal canal, give some strength to the anal canal. That's come and gone, is not available anymore. We used to do radio frequency ablation where we put needles into the anal canal and we use radio frequency to increase collagen deposition and shrinkage of the anal canal. So now what's available in terms of more advanced therapy is other than the surgical options, meaning if you have a tear in the anal sphincter, we can do an anal sphincter repair. Of course, we can remove the colon and give you a colostomy. We very rarely do that. Now what's available is called InterStim, and InterStim is a sacral nerve stimulation device, and it's an implant that we place, very small, under the skin, that previously, many years ago, it was shown to improve patients with urinary incontinence, and a lot of patients have both prior, related prior childbirth, and the technique was shown to be effective in patients with urinary incontinence, and they saw, oh my gosh, it helped patients with fecal incontinence as well. So now it's specifically available as a therapy for fecal incontinence, and we think that's very exciting, and it's an effective modality. So I talked about this. So this is the implant. It used to be a little bit bigger. Now it's gotten really, really small. And this is not true to size. It's probably the size of a thumb drive, the little thumb drive that you stick into the computer. So it's very small, very thin. You can barely see it. And it restores bowel function, maintain continence, and it works in the majority of the time. It's done in 3 phases. The initial phase, we call it P&E. So the initial phase is a 1-week trial, and we do that as gastroenterologists. We place the little fibers. We do it under X-ray. We have you a little bit of sedation, and we try it for a week to see if it improves. And it improves, then we go on to phase 2, phase 3 for the permanent implant. It's a therapy that's safe, it's minimally invasive, it's been used for over 10 years, significantly improved quality of life. I'm talking faster. So something to think about. It is something that really gets you back to your normal activity. You don't have to plan for that restroom. You can get out with your life. You can not be stuck at home. And it's covered by insurance. I think proven results, 89% in bowel control, significant change in quality of life. We said FDA approved, safe and effective. And I'm going to stop there. I'm going to introduce you to my partner, Dr. Paul Korc, is going to start talking to us. He is a therapeutic endoscopist at Mission. And I always say he is the best endoscopist that I know. And he's going to share with you some information today. Thank you for your attention.
Yes. Hi, everyone. Thank you. I'm so happy to be here. And like Dr. Nguyen said, we are advanced endoscopists, so we do a lot of therapeutic procedures, and we work real closely with the general gastroenterologist. And that kind of ties into my topic. It's also a really common entity, and it's polyps, especially colon polyps and other polyps or lesions of the GI tract. I'm going to share my screen here. I do have some slides that were let's see, they're part of a bigger talk, but so there's a lot of them, and I'm going to go quickly. Really, it's just to show some of the images and highlight what we do as advanced endoscopists. And I'm focused on the resection techniques, removing these polyps. So you're probably all familiar with polyps. You go in and get your screening colonoscopy, and all gastroenterologists are well trained in colonoscopy, and we are lucky to have a great group at Mission. So they identify polyps in the colonoscopy, and they're going to remove the vast majority of polyps that they identify. And you can see some examples here from really small up to sort of big, but then every gastroenterologist has varying comfort levels, and what we will get, this is an example of how we classify polyps. These are easy to remove when they have a little stalk. You just cut here. But if they're flat, that's one reason they get sent to us. If they look like this, then they may need a surgeon. Sometimes they're beyond what we can remove with the scope. But an example of what gets sent to us is this. This whole thing is a polyp. You can see it's kind of spreading all the way around, or almost all the way around the circumference of the colon. But the point of this talk is that these should be removed endoscopically. These are no longer being sent to surgery. And if they are, that pattern should be changed, because we can take care of the vast majority of precancerous polyps, or even those that harbor early cancer. So this is an example of how we attack it. You know, we take it off in pieces, and at the finished product is a clean base here with no more polyp.
Dr. Korc, we can't see your slides.
So here's
Dr.
another
Korc?
example, another really large, almost circumferential polyp. And then I go through some technique here, but the blue dye you see in there, that helps us delineate the base and the margin of the polyp, and that's the outcome. So these patients are cured, they avoid a surgery, and that's really how it should be nowadays. Here's another one. These polyps can sometimes be subtle, so you know, we look closely. I'm getting told I can't see any slides. I thought I did the share. Oh.
No, we can't see your slides. Can you hear me, Dr.
I'm
Korc?
sorry. How about now? Can you see them now?
Yes, thank
Okay,
you. We
good.
can see them now.
So I won't talk over everything again, but these are some of the small polyps that I alluded to. You know, these are going to be removed during your screening colonoscopy, because all gastroenterologists are trained to remove polyps. And then this is an example that gets sent to us, taking up almost 3/4 of the circumference, really big, really spread out, really flat. So it takes a lot of time and technique, dedicated technique, to remove these. But the point I was making is they should be removed this way. They shouldn't go to surgery unless there's cancer in them, and then of course that changes things. But most of these we can tell by looking whether they're cancerous or precancerous, and if there's no sign of cancer, we should be removing them endoscopically and sparing people's colons. So there's a final outcome there. That's all the defect, nice and clean, no polyp left. And then I had another, as I was describing, a similar example. That's when they're really flat, we do what's called an injection to help lift them up. And again, there's the final outcome. So these patients, like I said before, were cured without the need for surgery. This is the one I was just getting to when I realized that you couldn't see my slides, but it's not terribly big, but you can see it's extremely flat. It's really subtle. So you need, whoever's doing your colonoscopy really has to have a keen eye, and our good GI doctors do. And then they usually send it to us. Sometimes I make little marks around it, so I know after I've done my cutting that I know I've gotten the whole thing. And there you can see the undersurface intact, some vessels, but we usually put some clips there to prevent any bleeding. So if you do have a big polyp, or you know someone who does, and they should hopefully have avoided surgery nowadays, but we do have to do a close follow-up. They should have a colonoscopy again in 3 to 6 months to check the area. especially if it was removed in multiple pieces, which we call piecemeal. That's to make sure there's no fragments left. If we do a good job, and I always make sure to, then that's a very low likelihood of that. And this is a follow-up. So this is what we look for. It's a healed scar. So this is all scar tissue from where that one of those really big polyps was removed. But there's no evidence of any polyp whatsoever left behind. So that's the desired outcome. So another area which maybe you're less familiar with, although some of you I'm sure have heard of it, is Barrett's esophagus. So this is now in the esophagus, and it's a precancerous condition. It's often in people who have heartburn or acid reflux, not always. Some people have silent Barrett's. They've never had, significant heartburn symptoms. It's very common. I would guess even more common than this number of 6%. And if it progresses to cancer of the esophagus, unfortunately, esophageal cancer has a very low survival rate. So our job as gastroenterologists is to find it in the early stage and prevent esophageal cancer, because even with all the advancements in chemo and surgery, esophageal cancer is still a very deadly cancer. So just to jump into an example here, this is a woman who did have heartburn. Turned out she had Barrett's esophagus. This is normal esophagus, this paler color. Where it's pink is actually the Barrett's. It's the changes we see in the lining that indicates Barrett's esophagus. But if it's subtle, but if you can appreciate, this area is a little more raised than this area. And so there you can see it is kind of bumpy, very subtle, but you see this little bumpy architecture here. That's actually an early cancer, believe it or not. And even just 10, 15, 20 years ago, this would go for surgery. It's a horrible surgery. You have to remove the entire esophagus, reconnect it. Life is altered forever after that. But now if it's caught early enough, we can remove it. And these are some of the devices we use. I'll kind of go quickly over that. But there you see us sucking it up into this band here and then cutting. This is all done through the scope, and finished product, it's done. There's a little bump left here, which I took care of later, but that was non-cancerous. But here is like the scar, kind of like the one I showed earlier in the colon. You can tell all of that, that entire nodular area is gone. And we know if it's an early cancer, that's what T1A means, a very early superficial cancer, that we can avoid surgery, remove it like I just showed you, and long-term remission or cure is 94%. So it's a very effective technique, and it spares the esophagus. So that's really important. We've now extended this into even stomach cancer. Stomach cancer, fortunately, is much less common here, but it's very common in Korea and Japan. So they have a high incidence of stomach cancer. So they've developed techniques to remove early stomach cancers. These are just some of the tools we use. These are really tiny, super magnified in these pictures, but they're these little knives that go through the scope and help us carve out these lesions. And I can show you a quick video. But the pink area here is a cancer, an early cancer, but cancer nonetheless. Here we're avoiding surgery, so I'm injecting around it. And I'm not going to be able to go into too much detail because of time constraints, but this is a technique that's a little bit more advanced than what I was showing you before, because it's called ESD. It's a dissection. We actually can cut around the tumor and then carve underneath it with these special knives. You can see me making that initial cut at the edge. So instead of just hacking the tumor out in multiple pieces, we're actually carving around it and then going underneath it. And the goal is to get it out in one piece. So it's almost like a surgery. It's a true cancer removal, because we have the entire thing out in one piece. We know for sure that we have clean margins at the edges and on the deep side. And that's how we know that this patient is cured of cancer. So you can see me digging this specialized knife into the lining and then cutting the lining. So that's cutting around it. Eventually what I'm going to do is carve underneath it. This is the deep layer. It's very technically challenging because you have to avoid going too deep and tearing a hole in the stomach, obviously, but it's very safe when done appropriately. So we're cutting this layer. That's the tumor. Eventually the tumor is out, and that's our specimen. And that's what I'm talking about. Now we know, the pathologist can confirm for me that these margins, the edges, are all clear. So there's just quickly going through another example, but I'll show you the final outcome. So you have one clean removal area. And again, clean margins here. So I don't want to go into too many details. Well, what you may have been thinking, or even if you weren't thinking of it, what if they're a cancer and they're a little too deep in the wall? Well, if they're a full-blown cancer, still people need surgery. But I'll show you one more technique. When they're a little bit deeper, we have a nice new tool for small lesions. They can't be too big and spread out like that first one I showed you. But if they're small enough, even though they're deep, we can grab the lesion with this grasper, pull it into this special device. It actually deploys a metal clip down here, down deep. So you're actually closing the deep layer, and then the built-in cutting device cuts. So you can see in this picture, you've got the lesion, you've gone all the way through the wall, almost like a surgeon would, but your metal clip is clamping that wall shut in advance before you cut. So you're safe and protected. So it's not going to be necessarily applicable to every lesion, but it's important people are aware of this, because we can remove even cancers that are even a little bit deeper than the ones I showed you before. Here we are pulling it into this special device, and then what you see here is that clip I talked about. That's closing the deep layer. So again, we know we got the whole thing, and that's what's really critical. So it's almost like a surgery. So my conclusion is that really all non-cancerous or non-invasive colon polyps should be removed endoscopically through a colonoscopy in expert centers, not sent to surgery unless there's proven cancer and then it needs surgery. And even some early cancers, such as the one I showed you in the esophagus, in the stomach, or maybe even in the colon, can be removed through a scope. And then that technique is called ESD, when you're removing it in one piece. Not necessary for all lesions, but especially for cancerous ones, that's important. Thank you. Oh, this is where I learned some of these techniques. I was in Korea a few years ago. So this is, like I said, where they developed a lot of them. They let me, they trained me and showed me around. So thank you.
Thank you.